for T cells, but 85% of the cases are B cells lineage, so from the B cells. And it responds to chemotherapy. Also, we have some poor prognostic indicators. We have to know them. By the age, if the child is very young, less than 2 years, or older child, more than 9 years, for example, and WBC count are very high, more than 50,000, or central nervous system involvement. As well, we have Philadelphia chromosome. It will be discussed in the next presentation, but if it is associated with acute lymphoblastic leukemia, it is considered to be poor prognostic. So we have to know regarding the age, regarding the counts of white blood cells and involvement of central nervous system. In general, risk factors for having the malignancy of blood cells, it includes radiation, exposure to radiation, and myeloproliferative syndrome. It will be discussed later, I think. And also someone having Down syndrome is at risk of having acute lymphoblastic leukemia and prior chemotherapies. For the clinical features, we mentioned it's affecting erythrocytes, thrombocytes, blood cells. So if we have anemia, it will, the clinical symptoms, we will find pallor, fatigue in the patient. Thrombocytopenia, there could be here, purpura, discoloration in this small, purpura a bit larger. And they also suffer from bleeding. And also there could be infection due to ineffective and immature white blood cells. Bone and joint pain, it is common, especially in acute lymphoblastic leukemia due to invasion of periostome. As well, we could have splenomegaly, hepatomegaly, lymphadenopathy. This is a child suffering from acute lymphoblastic leukemia. He's having cervical lymphadenopathy. You can see the enlargement in his neck. So how we diagnose this patient? In general, first we should order complete blood count, CBC, to look for leukocytosis, increased number of white blood cells, anemia, and thrombocytopenia. So as well as we look the blood smear. In the blood smear, we could find blast cells. Blast cells mean immature cells. But the most accurate test is bone marrow biopsy. Also, we do flow cytometry. We mean by flow cytometry, so we can know if it is from lymphoid or it is from myeloid. In acute lymphoblastic leukemia, we could find a lot of blood cells from lymphoid lineage, and they should be more than 20%. The same thing goes for the acute myeloid leukemia. There is blood cells, and it is from myeloid lineage, and they are more than 20%, and so on. And we can confirm the lineage by immunophenotyping. We mean by that there are some markers on the surface of the cells, and from these markers, we can know if it is from B cells, for example, from T cells, and if it is from acute myeloid leukemia. So just to be remembered, some of them are important. If you want to memorize about the B type, they are usually big numbers, 10, 19, 22. Regarding the T type, they are small numbers, 2, 3, 7, like this. But for the stem cells, they are CD34. So try to remember this. Regarding treatment, actually treatment part is not important. It is very complex. And in general, there are chemotherapy. But for acute, there is treatment for emergency. We need to give antibiotics for infection, blood transfusion for anemia, platelet transfusion for bleeding. So this was part for acute lymphoblastic leukemia. Okay, which one is more common? What do you think?
B cell.
Yes, there is B cell type. regarding the markers, which of the following is a stem cell marker?
CD34.
CD34. And if we are talking about B cells, we have like
19.
If we are talking about T cell, 3 and 2, and this is yes. So we finished regarding acute lymphoblastic leukemia. Now we will start with the chronic. So it is most commonly at age 50 in the people, most patients of 60 years. And it is also called caused by monoclonal proliferation of lymphocytes that are morphologically mature, but functionally they are defective. They are not doing their job. They are not becoming plasma cells. They are not producing antibodies. But in general, this is least aggressive type of leukemia. Also, almost all cases involve well-differentiated B lymphocytes. So here also, B type is more common. They are usually asymptomatic at time of diagnosis, incidental discovery due to lab tests, for example, CBC, and they have painless lymphadenopathy, usually cervical. I think it's very characteristic, you have to know. And as well as they will have hepatosplenomegaly, infection due to defect in white blood cells. So this female is a patient, 67-year-old. She's suffering from chronic lymphocytic leukemia and there's painless lymphadenopathy in the cervical. For diagnosis, as usual, complete blood count to look for leukocytosis, anemia, thrombocytopenia, neutropenia. And in blood smear, we can find mature lymphocytes, but there is a characteristic thing which is called smudge cells. They are fragile leukemia that are crushed by slide. So this one is very characteristic. You have to know smudge cells, fragile leukemia cells crushed by the slide. But the most accurate test, we have flow cytometry showing CD5 marker on the B cell. CD5 marker should be normally found on T cells, but if you find it on B cells, it is abnormal, and it is one of the accurate tests for diagnosis. But we can also go for bone marrow biopsy. Regarding treatment, as usual, chemotherapy, but it is not our concern, it is more beyond. So as you can see, this is smudge cells. They are fragile cells on the smear, as you can see, for chronic lymphocytic leukemia. Now we finished regarding the acute lymphoblastic leukemia, chronic lymphocytic leukemia. The last thing is hairy cell leukemia. It is also a malignant disorder of well-differentiated B lymphocytes. As you can see, B cells are dominating, most of them, and it is considered to be 2% of adult leukemia, and also in older people, median age 50 to 55 years. Their presentation is similar to chronic lymphocytic leukemia, except that they rarely have lymphadenopathy. As well, they could have splenomegaly. For diagnosis, CBC, for leukocytosis, for anemia, for thrombocytopenia. In blood smear, they show hairy cells. Hairy cells considered to be pathognomonic. When we say pathognomonic, khalas. When you see it, this is the diagnosis. So as you can see on the blood smear, you have cytoplasmic projection like hair, so they call it hairy cells, which is characteristic and pathognomonic for hairy cell leukemia. Treatment, also chemotherapy. So to summarize in 1 minute, just to be fast, so we have acute lymphoblastic leukemia, it's affecting the children, and also you have to know some of the markers, especially the B type and T type, and you have to know that B type is more common. And we have some treatment for emergency, like antibiotic, blood transfusion, and for lymphocytic leukemia, which is affecting the old patients, It's characterized by having also painless lymphadenopathy. Also, they have smudge cells on the blood smear, fragile leukemic crushed cells. And we have, it's also affecting the B cells most likely. At the end, we have hairy cell leukemia. It is also affecting B cells and the B type of cells. And we have pathognomonic signs, or on blood smear, we can see cytoplasmic projections of the cells. So these are the questions. The main features of acute leukemia. What do you think the answer?
Abnormal blast in the circulation.
Yes, we are talking about acute leukemia. They have blast cells, which are immature cells in the circulation. And there is no increase in mature white blood cells. Indolent, we mean by that slow growing or slow proliferation. It is not like that. Cytosis is just like suffix, for example, phagocytosis and these things. So the right answer is abnormal blast in the circulation. So the second question, which one of these cases had bad prognosis in acute lymphoblastic leukemia?
Age of patient 15 years old.
Yes. So why it is not, for example, B cells, acute lymphoblastic leukemia? B cells is just like most common type, and 85%, for example. It is not considering bad prognosis. Female, there is no age difference, gender difference, and no CNS involvement is wrong. If we consider it bad prognosis, there should be CNS involvement. As you can see here, bad prognosis, if he was very young or old child, and white blood cell count is very high, and CNS involvement, as well Philadelphia chromosome involvement here. So smart cells are characteristic of
CLL, chronic lymphocytic leukemia.
Yes, chronic lymphocytic leukemia. We can see on the blood smear these fragile leukemic cells. So what can you see in this picture, and what is the disease?
Hairy cells. Hairy cell.
Yes, hairy cells. So the disease itself, we call it
Hairy cell leukemia.
hairy cell leukemia. Most of the cells are T type of cells or B type.
Well differentiated B cells, right?
Yes, B cells. Well differentiated B cells. So these are my reference if you have any questions.
Thank you very much for the great presentation.
Allah.
Is my voice clear for you?
Yes, it is.
Okay. And the presentation is visible?
Yes.
Okay, thank you. So hello, I'm Rahaf Mohammed. I'm fourth year, and I will start with the acute and chronic myeloid leukemia. So this is our table of contents. Our main focus now is the myeloid leukemia. Inshallah. Okay. Okay. Bismillah, we will start. For the hematopoiesis pathway, our main focus now is for granulocytopoiesis, and we will focus for the acute myeloid leukemia on the myeloblast. So in cases of acute myeloid leukemia, we have for the myeloblast, there is a certain causes or risk factors that will cause this myeloblast to continue dividing and proliferating without it begin differentiating to mature cells like the eosinophils, basophils, and neutrophils. So we will have many of these myeloblasts, and those will accumulate in the bone marrow and the bloodstream, and they will infiltrate in different tissue, causing different signs and symptoms. So in the end, we will have many immature white blood cells, and there is no functional white blood cells, either eosinophils, basophils, or neutrophils. Okay. So starting now with what is acute myeloid leukemia. So it's a order of early hematopoietic stem cells, as we said, mainly the myeloblasts, and it results in unregulated growth and differentiation of white blood cells in the bone marrow. So because it's acute, there will be a rapid onset and progression of symptoms. And we will talk about these symptoms later. Now, what is the age group? The age group mostly adults, and they are from 13 to 40 years old. So what are the risk factors that will cause myeloblasts to keep proliferating without differentiating to mature cells? First of all, we have exposure to radiation or prior chemotherapy. And both of them will cause DNA mutation, and DNA mutation will give this immature cells, the myeloblasts, the ability to keep replicating without developing apoptosis and without differentiating to the mature white blood cells. Then we have myeloproliferative disorders, and those are disorders such as polycythemia, essential thrombocytosis. Those are cellular proliferation of hematological cells, and those diseases have the ability to progress to AML in a certain time of their course. Also, we have patients with Down syndrome. They can develop AML. And most importantly, we have translocation in chromosome, between chromosome 15 and 17. And this is very important and high yield, and we will talk about the presentation is still visible, or?
No, it has been disappeared.
Okay, just a second. Sorry for the inconvenience, just a second. Is it clear now?
Yes, clear.
Okay, sorry. So we'll continue. So yeah, we will start. We will continue with the ABL, or acute promyelocytic leukemia. So acute promyelocytic leukemia, it's one of the subtype of acute myeloid leukemia. It's the third subtype. We have 6 subtypes, but most importantly, and the most high yield one is the M3. So acute promyelocytic leukemia is characterized by presence of the translocation between chromosome 15 and 17. So there will be an exchange genes, and this exchange will lead to a fusion gene. This particular mutation called PML RARA. And this mutated gene will have the same end result, which is the myeloblasts replicating without differentiating to mature white blood cells. So what's more important, that this particular type is associated with DIC, or disseminated intravascular coagulation, and we can say it is the only part that can develop DIC. So how DIC occur in cases of ABL? Myeloblasts will release tissue factor, and this tissue factor, as we know from before, it activates the extrinsic pathway, which causes coagulation. And also at the same time, this myeloblasts will release tissue plasminogen activator, which causes also at the same time fibrinolysis. And this imbalance between clotting and breaking down these clots will cause a high risk of bleeding in different tissue. For example, patients will come with intracerebral hemorrhage or pulmonary hemorrhage. It's DIC is the common initial presentation, along with the signs and symptoms of pancytopenia, that we will talk about it later as general for the AML. Also, we have a characteristic sign for this ABL is finding our rods in the biopsy. So what is our rods? Our rods are crystallization of myeloperoxidase, and myeloperoxidase is an enzyme normally found in the neutrophil granulocytes. So this enzyme will be crystallized and will form a pink-red color, rod-shaped, granular cytoplasmic inclusion bodies that will be found in the malignant immature myeloblasts. So if we have taken a biopsy, as you can see in the picture, in the red arrow, this rod shape, our rods is the characteristic sign for the ABL. Now, what is the treatment for the ABL? We have all the trans-erythonic acid, and this is a type, and this is a form, sorry, of vitamin A, and it promotes differentiation of the myeloblast to the granulocytes, and it's highly effective and has good prognosis. So till now, everything is clear about ABL.
You said that the over roads are the characteristic sign, but can you demonstrate what are they exactly?
Our roads
Yes.
are those are crystallization of the myeloperoxidase enzyme itself. And okay, thank you. And next, we will talk about the signs and symptoms of AML. Now, constitutional symptoms like weight loss, night sweats, and chills. And we said that our main problem in this condition is that the myeloblasts will keep replicating in the bone marrow, and they will be taking so much space in the bone marrow that it starts to take the nutrients from other cell lines, like the RBCs and platelets. So they won't allow the replication of other cell lines. So in this case, we will have anemia, thrombocytopenia, and tons and many of non-functional immature white blood cells. So signs of anemia is pallor, fatigue, and cases of severe anemia, we will have dyspnea. And the symptoms, for thrombocytopenia, petechiae, purpura, and bleeding, especially from the gums. Also, we will have recurrent infections such as pneumonia and UTI because of the ineffective and immature white blood cells, which will create an intact immune system. Also, in case of other subtypes like M4 and M5, we will have CNS infiltration, and the patient will present with symptoms like headache and visual disturbance. And as mentioned before, in the APL, it's mostly associated with DIC. The sign that the patient will present with swollen bleeding gums, especially in type M4 and M5. And also we have leukemia cutis, and those are skin infiltration and nodules. They will be purple to gray to blue color. I will show a picture next to the slide. Also, we have enlarged lymph nodes, hepatomegaly and splenomegaly, but it's less common. Now here we have important notes, and it's high yield. If we have a patient presenting with signs of infections, and we have known that the patient has a history of recurrent and frequent infection. And when we performed CBC, we found that the patient have leukemia or decreased number in neutrophils. So first differential diagnosis come to your mind. Everything clear in this slide?
Yeah.
Okay. Those are the pictures for the signs. As you can see, the gingival hyperplasia and the nodules found in the face and in the extremities. So now, just to organize our thoughts, we said that the patient will present with symptoms with pallor, fatigue, easily bruising, purpura, recurrent infection, and they will have signs of these nodules and hypertrophy of the gums, and also signs of DIC in case of ABL. So we will suspect AML. So our next step is to confirm this diagnosis. So we will start first with the initial testing, which are the CBC with a smear, and it's the best initial test. When we do the CBC, first we will find either leukopenia or leukocytosis. So that means that the number of leukocytes are not reliable diagnostic marker. Also, we will find anemia, and we find thrombocytopenia. And for the peripheral blood smear, we will find myeloblast cells, the immature cells. Also, we will find electrolyte disturbance, like hyperuricemia, hyperkalemia, and hyperphosphatemia. Now, this electrolyte disturbance mostly be seen as a result of treatment of leukemia. When the patient is treated by the chemotherapy, there will be a complication called tumor lysis syndrome. I will talk about it and the complication of the treatment, which will lead to myeloblast destruction due to the chemo. So this destruction of the myeloblast will release potassium, phosphate, and uric acid. Next, for the immunohistochemistry, we will have positive myeloperoxidase. And for the genetic testing, in case of A1517 translocation. The most accurate test is the bone marrow biopsy with the flow cytometry. We can classify the type of the AML by it, and we will find that the bone marrow will be infiltrated with myeloblasts more than 20%. And of course, we will find our rods specifically in the APL. Now here, here important notes that in case of a high number of white blood cells, leukocytosis, we have risk of leukostasis, which is the myeloblast will be occluding the small circulation, the microcirculation. Those can lead to pulmonary edema, CNS symptoms, ischemic injury, and DIC. Now here we can see the differentiation between the myeloblast and lymphoblast after we have taken the biopsy. And here we can see that the cell can be distinguished by the morphology, cytogenetic, and immunophenotyping. So the myeloblast is larger in size, has more amount of the cytoplasm. It has a visible nuclei and fine granules, also a presence of our rods and myeloperoxidase, and negative for the TDT. Okay. Now, lastly, for the AML, the treatment. Now, for treatment of emergency, first we have the infection. We will treat it by the antibiotics. The anemia, we will give blood transfusion. And for the bleeding, we have the platelet transfusion. Treatment of leukemia itself, we have aggressive combination chemotherapy, but unfortunately, AML does not respond well to the chemotherapy. Next, we have the bone marrow transplantation. It's done in subtypes of favorable and in cases of lack of appropriate response to chemotherapy. Now, what are the complications of doing the chemotherapy? We said first, tumor lysis syndrome. The blast will be destroyed by the chemotherapy. As we mentioned, there will be hyperuricemia, hyperkalemia, hypocalcemia, and renal insufficiency. And we can prevent this complication by the good hydration for the patient. Now, here we have high yield. We should start with the alloprenol or buricase. In cases, if we found that the white blood cell count are very high, and we need to use both these drugs to decrease the amount of the serum uric acid to protect the kidneys from any damage. Okay, so everything clear for the AML? Okay, any question for this part?
No, you said that in the biopsy there will be more than 20% of myeloblast, right? They will. Is there any CD marker or something like this for this myeloblast? Or by microscope it could be, I mean by the biopsy itself, the morphology.
There are, I think, CD33, but it's not CD33. I will make sure from it, and I will
okay, no,
refer. Okay, thank you. Any other questions?
No, thank you.
Okay, thank you. Now we will complete with the CML. CML, we have normal differentiation of the cells, but our main problem is that there is increase in the proliferation of these mature cells. We have in the eosinophils, basophils, and neutrophils, and also in the promyelocytes, myelocytes, and metamyelocytes. Okay. Okay, so what is the CML? It's a clonal expansion of myeloid progenitor cells, the mature cells, and we have BCR-ABL translocation should be present to diagnose CML. And because it's chronic, we have a slower onset of symptoms. The age group that will be affected, mostly middle-aged patients, and median age is from 40 to 60. So what are the risk factors or what causes this high proliferation of these the genetic association, what we mentioned, BCR-ABL, which is Philadelphia chromosome translocation between chromosome 9 and 22. Now, for the CML, we have phases. We have a chronic phase, accelerated phase, and blast crisis phase. And each of them have particular signs and symptoms and will be diagnosed with certain amount of number of RBCs or ablations. Now, for the Philadelphia chromosome, genetic hallmark of CML, and we said that we cannot diagnose CML unless there is a Philadelphia chromosome. And it's caused by the transgene chromosome, and this translocation will cause a fusion gene, which is BCR-ABL, and it will be detected by BCR or FISH analysis. This mutation will produce tyrosine kinase, and this tyrosine kinase will give long life for the myeloid progenitor cells, causing it to accumulate in the bone marrow. Patients who doesn't have this mutation have a shorter survival time and more poor response to the treatment. Now, what are the signs and symptoms in general for the CML? We have many of them will be asymptomatic at the time. We have anemia and thrombocytopenia, symptoms of anemia like pallor and fatigue, and thrombocytopenia, petechiae purpura, and bleeding. And as we mentioned, the same reason that too much accumulation of the mature cells in the bone marrow, so there won't be enough nutrients for the other cells to be differentiating and proliferating. Also, we have constitutional symptoms, weight loss, anorexia, fever, night sweats, and chill, and we have also early satiety. For the signs, we have massive splenomegaly with left upper quadrant pain, and this is mostly because of the deposition of leukocytes and extramedullary hematopoiesis occurred to produce more cells. Also, we have hepatomegaly and lymphadenopathy. Now, starting with the phases of CML, first phase, we have the chronic phase, and this phase, the patient will be asymptomatic. If they develop symptoms, they will have constitutional symptoms and splenomegaly. And in this chronic phase, we have it will be detected by the CBC. There will be a leukocytosis, massive increase in the white blood cells, and in case and then and when we do a biopsy, there will be a few blasts, a few number of blasts, less than 2%, and the mature cells are higher in amount. And patients in chronic phase, they can last from 3.5 without treatment or bleeding. So in summary, the patient will be either asymptomatic or have constitutional symptoms. It will be catched by the massive increase in the white blood cells, and the biopsy will have a higher number of the mature cells. Next, we have the accelerated phase. And this accelerated phase, it will be detected in case when the patient starts to take treatment and there will be no response to the treatment, we will know that the patient has reached the accelerated phase. And this phase will last 4 months. And if the patient has reached this accelerated phase, it's the transition phase toward the blast crisis. So we know that the patient would have this blast crisis phase next. It will be identified by increase in peripheral and bone marrow blood counts. So over time, we will have increase in replication, more mutation will occur, and leading to fewer differentiation to mature cells. So the number of non-functional white blood cells will increase slightly in this phase. And that will lead to decrease in the space of the bone marrow for the other cell types. So that lead to a decrease in the number of platelets and RBC. Also, most important, we will suspect this phase when the differential shows an abrupt increase in the basophils and thrombocytopenia, and mostly basophils because there is not many diseases that have basophilia. So if we have seen increase in the basophils in the biopsy, we will suspect that the patient has reached accelerated phase in the CML. And this is for the accelerated phase. Lastly, for the blast crisis phase, it resembles the acute leukemia phase, and everything in the accelerated phase, it gets worse. So we have increase in the, will be a lot of less functional white blood cells. There will be thrombocytopenia and anemia and risk of infection. And it occurred because a large percentage of untreated CML patients will reach this phase. The survival rate for this for patients developing to this phase are from 3 to 6 months, and the number of blasts will be more than 20% in the periphery or bone marrow, and mostly will be myeloblasts. So in summary, for this phase, we will have the patient, mostly it's for patients untreated. Their survival will be from 3 to 6, and they will have mostly symptoms like acute leukemia, an increased number of blasts in the biopsy, thrombocytopenia, and risk of infection. Everything is clear in this slide. It's very important.
Yes.
Okay, now for the diagnosis, starting with the initial test, we have the CBC with a smear. For the CBC, we will find leukocytosis, increase in the number of white blood cells, and sometimes it can lead to massive increase and severe increase of white blood cells, reaching as 5,000. For the peripheral blood smear, we have granulocytes, predominantly neutrophils, and in all stages of its maturation, we will have the promyelocytes, the myelocytes, and metamyelocytes. For the bone marrow biopsy, we will find leukocytosis, and we can also determine that by the increase in the basophils, granulocyte hyperplasia, and we have also what's called myelocyte bulge, which is that the number of myelocytes is more than the metamyelocytes. Also, we have increase in the LDH, the uric acid, and sometimes we have increase in the B12. And here we can find a small, okay, here's some a small table for differentiating between the chronic phase and advanced. And as we can see, the normal RBC in the chronic phase, thrombocytosis, and for the advanced and blast phase, we have anemia and thrombocytopenia, an increase in the number of myeloblasts in the bone marrow. And also we can see that the basophil is the telltale sign, which is the key sign for the CML, especially in the accelerated phase. Now, what is the most accurate test to diagnose CML? We have finding Philadelphia chromosome by the PCR or FISH analysis, which is showing the translocation between chromosome 9 and 22. Now, here we have what's called, it's high yield, we have the leukemoid reaction. Leukemoid reaction is a normal acute inflammatory response. It's due to infection, and that will lead to increase in neutrophils. So it's the same thing for the CML. There will be increase in the neutrophils. But the difference between leukemoid reaction and the CML, first we have what is called leukocyte alkaline phosphatase.
ده صار 40 أو 46 شيء كذا.
Can you mute yourself please?
في 40 قال خلنا مو رقمي صاحبي عادي اصبر.
آخره 18 ولا 70.
Okay.
Go ahead, please.
Okay, so the difference between leukemoid reaction and CML, for the leukemoid reaction, we have what's called leukocyte alkaline phosphatase, and it's normally found in the neutrophils. So this leukocyte alkaline phosphatase, it will be low in the CML, but high in cases of leukemoid reaction. And also there is no myelocyte bulge in leukemoid reaction. So in conclusion, in cases of leukemoid reaction, we will have increase in the leukocyte alkaline phosphatase, and there is no myelocyte bulge. And in case of CML, we will have low leukocyte alkaline phosphatase with myelocyte bulge. So everything is clear here?
Yes.
Okay, thank you so much. Okay, now lastly for the treatment, we have for the chronic phase and for the blast crisis. For the chronic phase, we have the tyrosine kinase inhibitor and like amitinab. And for the young patient, if we found matched siblings candidates for them, we can perform allogenic bone marrow transplantation. In case of blast crisis, we will have same treatment for acute leukemia and or second generation tyrosine kinase inhibitor plus bone marrow transplantation. Okay, and that's it. Thank you. We will go to the questions now. And okay, any question?
Now I have one question, please. You said that sometimes in the CML there is increase in the B12 level.
Yes.
Is there any reason for this, or it is no?
Absolutely. Actually, there is. I didn't find any reason for. There is no reason for. I didn't find any reason for the increase in the B12 actually. But I will search more, and if I find, I will. Tell you.
No problem at all. No problem.
Okay. Thank you for your question. Okay. Okay. Now starting with the first question. Anyone would like to read?
Okay. Previously healthy 61-year-old man comes to the physician because of 3-month history of intermittent fever, easy fatigability, and 4.4 kg weight loss. Physical examination showed conjunctival failure. The spleen is palpated 5 centimeters below the left costal margin. Laboratory studies show a leukocyte count with increased basophils, platelet count of 455,000, and decreased leukocyte alkaline phosphatase score. Peripheral blood shows increased number of promyelocytes. Myelocytes following is the most likely diagnosis. CML, I think.
Okay, CML. You want to justify your answer?
Now there, it's obvious that the patient is in the CML in the blast phase. The myelocytes, the promyelocytes, and metamyelocytes are all increased. The leukemoid reaction, we cannot say this because the leukocyte alkaline phosphatase should be high there. And the other lymphocytic or there's no evidence for lymphocytic problem.
Okay, correct. Thank you so much. So just to clarify for everyone, we have excluded leukemoid reaction because of we have leukocytosis and fever, but the lab score is decreased. And as our colleague mentioned, the CML is the correct answer because we have the low lab score. There also increase in the promyelocytes, myelocytes, and metamyelocytes, and leukocytosis and splenomegaly. We have also excluded acute promyelocytic leukemia because only myeloblast was found, and also there is thrombocytosis, and there is no evidence of our roads or translocation of between 15 and 17 chromosomes. Also, it's not CLL, of course, because there is no Bell-less lymphadenopathy or lymphocytosis with smudge cells. So as it's mentioned, CML is the correct answer. And thank you. Okay, next question. Anyone would like to read?
Yes, can I?
Okay, no problem.
68-year-old man comes to his physician because of fatigue, night sweats, chills, and 5 kg weight loss during the past 3 weeks. 8 years ago, he was treated for a hematological malignancy after biopsy of a neck swelling shows CD15 positive and CD30 positive cells. Physical examination shows conjunctival pallor and scattered trachea. The peripheral blood smear is shown. Which of the following is the most likely explanation for this patient's correct condition? A, B, C. It's AML. So B, A, chronic.
Exactly. B, right? You said B?
Yes.
Yes, that's correct. That's correct. You want to justify your answer?
Probably it's like a recurrence or transformation of a previous malignancy, and also the aura roads.
Exactly. Exactly. The aura roads concludes the case. Yeah, the aura roads, and also it's radiation induced because the patient has hematological malignancy, specifically Hodgkin lymphoma. Those are the markers for Hodgkin lymphoma, and the patient has been treated with chemotherapy for this lymphoma, and due to the radiotherapy, the patient developed myeloid leukemia. So also we said that acute myeloid leukemia, sorry. We excluded accelerated phase of chronic myeloid leukemia because as we can see, the symptoms are acute, and treatment failure and patient malignancy was not leukemia, as the marker has indicated. And also the CML would have been positive for the Philadelphia chromosome, and there will be abrupt increase in the basophils. So we don't have any of these, so we cannot say it's accelerated phase of, and it's not ALL because mostly ALL for those less than 13 years old. Also, there is no lymphadenopathy, no bone or joint pain, and also there is no evidence of marker CD10 or 19. So as our colleague said, the answer is B. Yes. And thank you so much. Thank you for participating also.